Good morning.
How are y'all?
Good morning.
Hold on, I'm reading y'all's chats for a second. Okay, I see y'all talking about flagging some of the questions, and there are some of the questions that were looked at yesterday after y'all tested, not the ones this morning, but yesterday. And there were some parts not finished or some misspellings, and points were given for those. I don't know exactly which questions those were yet, but when we have time for exam review, we'll do that, and y'all know, okay? Anything else for me this morning? One question was repeated. Okay, well, you can't get it wrong. You can't get it wrong twice. So I'll look at that. Anything else? All right, you're ready to start gas exchange? I think she said she's going to release the grades this evening sometime, this afternoon to evening. Yes, Kristen. Or Christine, sorry.
Yeah, it's Kristen. I was wondering how you were able to put the TBI questions together, guys. When we go to practice questions, we can't narrow it down just to TBI. Is there a way that we can do that?
I'm not sure. I'll have to go in student view and look because it's an administrative view that I can do that in. But you may have access to do that. Remind me at the end of lecture, and I'll, right when we get off, I'll go into the student view and see if you can do it.
Okay, thank you.
Okay, you're welcome. Okay, test 2 is covering immunity, gas exchange, and not metabolism, metabolic, sorry. And next week we'll be doing that part of it, the metabolic part. I'm getting my syllabus up so I make sure I tell you the right thing. And metabolism is liver failure, pancreatitis, failure to thrive, and then Cushing's and Addison disease. Anything else?
I have a question.
Yeah.
I was going to ask you if you had a chance to put together a Raising the Bar for immunity.
No, I haven't. I'll get that done today for you, though.
Okay, awesome. Thanks.
You're welcome. Anything else? Oh, exam 2 is immunity, gas exchange, and metabolism. Hold on, let me look at the syllabus then. It's F&E? I haven't done next week's lecture. 1 minute, let me look at the calendar. I think I have it up. No, you're right. I'm so sorry. It's fluid electrolyte. So fluid electrolyte will be your extracellular fluid, which is the heart failure. It will be hypokalemia, which is also part of failure, and acute renal failure, which is the hyperkalemia. So second exam is immunity, gas exchange, and F&E. Thank you for the correction. Anything else? Y'all have probably been pretty mad at me if I showed up and taught something different next week. All right, let's do gas exchange, okay? I know. You ready? All right. So this is just some general stuff about gas exchange. And our exemplars are cystic fibrosis, they're anemia, acute respiratory distress, and pulmonary embolism. So which one of those exemplars causes chronic hypoxia? There's more than one. Yeah, that's right. Cystic fibrosis and anemia will cause that. And then complications that are related with chronic hypoxia. If you're chronically hypoxic, what can happen to you? Yeah, I feel like I'm chronically hypoxic this morning. I'm like out of breath and I have no idea why. So if you hear me like breathing heavy, I'm so sorry. It's embarrassing. So all those things, yes, clubbing of hands or fingers actually. You'll actually have an increase of CO2 in your blood, which is called the CO2 narcosis. Cord pulmonale, do y'all know what cord pulmonale is? That's right. It's right-sided heart failure, but it's due to respiratory, not to cardiac. And then which one of ours would be acute hypoxia? I'm going 2 left. I'll give you a hint. Yeah, pulmonary embolism and acute respiratory distress. And these cause hypoxia. If you think about what they do, they either are obstructing your airway or they're impeding circulation, right? So they all cause hypoxia just by the inadequate amount of CO2 that's available for delivery, right? So the disorders are either respiratory obstruction or inadequate circulation. And some of our general nursing interventions, you want to maintain a good pulmonary hygiene to prevent hepatic loss. So if you have this hypoxic loss, what are the things that you need to do for that? What are some things you do to promote good pulmonary hygiene? That's right, you're going to do deep breathing, you're going to sit up. So you want to maintain a patent airway. So if that's an unconscious patient, you're going to have to position on the side. If it's a conscious patient, you want to elevate the head of the bed. Sometimes they want to be in that tripod position where they lean forward. It allows for greater intake of volume of air. You need to be encouraging that coughing and deep breathing. Suction the patient as needed. Why is adequate fluid intake important? Yeah, it helps liquefy those secretions, and liquefied secretions that are thinner are easier to get out than those thick plugs. Okay. You want to encourage exercise and ambulate if it's indicated by their condition. Some conditions do not indicate that. You want to administer expectorants. Now, with expectorants, those make them cough, right? Because they have to get the gunk and the mucus and the thick secretions out of their lungs. The only way an expectorant works is if they're actually coughing and productively coughing that up. And then you want to administer oxygen if needed. Hypoxia, some of them they're the same way. Yes, Jessica.
So with COPD, we would give like low flow oxygen because we were, scared that it would kind of go south if you gave them high flow. With like CFE and PE and anemia, we give high flow oxygen.
Yeah, you pretty much all of them you'll give high flow oxygen because these are more of a chronic state than just needing just a little bump of oxygen. Okay, so some of the measures to implement the decreased hypoxia are some of the same ones that you'll do to prevent those episodes also. Part of it is assessing whether or not the patient has a patent airway, and that's your first and your highest priority. You always have to make sure there's a patent airway. So some of those ways are, can this patient speak? Are they having difficulty speaking? If they're having difficulty carrying on a conversation or speaking in a full sentence without stopping, then they probably have some level of hypoxia going on just because they can't finish that sentence. So you need to make sure you have them head of bed up, and that's when you would begin oxygen on these patients. If the patient is coherent and is able to speak to you in in fluid sentences, then you continue to assess them to try to find out what this problem is. You want to evaluate the secretions and if they have an ability to cough and clear their own secretions, or do you need to suction them? And what does their breathing look like? Are they using accessory muscles? Are there retractions? Are they needing a tripod? And you need to maintain a calm approach as a nurse. And why is this necessary? What happens if your nurse sees you? Yeah, anxiety. So what happens if your nurse sees you all, what am I going to do? What am I going to do? And run around the room crazy. It makes them anxious. And what does anxiety do to that patient? It increases metabolic demand. What does it do to their oxygen requirement? Yeah, it increases their oxygen requirement. So it gives them the potential for more hypoxia or a greater hypoxia event. Okay. So when you're assessing, you're also assessing that color of their skin. I mean, what do they look like? Are they sweating? Do they have diaphoresis? What do their vital signs look like? Are there dysrhythmias? They can have those PCs or the PVCs. You can see them on the monitor. They can also be tachycardic. I talked a little bit about what does their breathing look like? Are they using those chest muscles? But what does their chest movement look like? Is it symmetrical? Is it moving effectively? Obviously, you're going to listen to breath sounds. You're going to be monitoring the blood gases and also their pulse ox. So now we're going to get into cystic fibrosis. What do you know about cystic fibrosis? Genetic, that's right. Usually diagnosed when they're children, pretty young. Okay, so here we have a kid. Autosomal recessive, yes it is, and that's correct, there is no cure. It does have poor prognosis. They're usually growth restricted. They're small in weight. Yes, lung transplants is the only way to really fix them, and a lot of them don't do well with that either. Okay, so you have a 2-year-old. So you have a 2-year-old, Katie Mitchell. She's admitted to the PICU with pneumonia. This is her second admission with pneumonia in the past 6 months. Your assessment of Katie reveals decreasing breath sounds on the right side in the base of the lungs and rhonchi scattered on upper lobes and dusky skin around her mouth. Her respiratory rate is 42 and shallow, temperature is 101, heart rate is 165, blood pressure is 80/44, pulse ox is 82, and she's on room air. She's in the 15th percentile for height and weight by age. Respiratory therapy just completed the nebulizer treatment of Ativan and Xopenex, and CPT is involved, Atrovent and Xopenex. And CPT is provided, and she has these ropey, thick secretions that are suctioned from the patient. After these treatments, you reassess the patient and find her respiratory rate is 34, her heart rate is 178, and her pulse ox is 88%. She's been placed on BiPAP with humidified oxygen at 3 liters. You have an order for an IV bolus of D5-LR at 20 mLs 2 times, and then you follow up maintenance fluid of 50 mLs an hour. The pulmonary resident wandered out of the room briefly, and after mumbling something about ordering a different nebulizer treatment, he's gone to the station, and Katie's mother is crying and asks what's wrong with her baby. Okay, so what is cystic fibrosis? Y'all told me a little bit about it. It is inherited, so it's genetic. What does it do? We know it causes thick secretions. Why does it cause those thick secretions? Alters sodium channels. Yes, it does. Yes, it's a mutation of a gene. So it's a dysfunction of the exocrine gland. Yes, see, y'all reading my mind. So instead of these clean, clear and thin mucus, it's very thick and sticky, tenacious. Yes, they reabsorb their sodium. That's right. And who's at greatest risk? We talked about that it is genetic, but it's also mostly Caucasian, and a lot of Irish descent have it that carry the trait. So how do you diagnose it? Sweat test, that's right. So a sweat test is performed, and a lot of times in babies, they don't quite sweat yet when there's when they're worried about whether or not they have cystic fibrosis in a patient. They don't really sweat yet, so you have to wait a little while to be able to do a sweat test. Other ways to do it are pancreatic enzymes, the decrease or absence of that trypsin. And if they're having problems absorbing fat, so they have decreased fat absorption. And so how does this impact the body? What does it do to the lungs? What kind of obstruction is it to the lungs? Think about it. It's a mechanical obstruction, right? Because you have this thick mucus that's plugging the area. So when you have this thick mucus that's plugging it, you're actually decreasing the amount of air that the lung can take in. So that's the functional capacity of the lung. And that thick mucus, that's right, it does cause collapsing of the lungs and areas of the lungs. And when you have the reduced areolas or the aeration that's in the lungs, what do you have? An impaired gas exchange, right? What else does this thick mucus do? Infection, that's right. So it causes a very good and high probability of bacteria growth, and also not only just the obstruction, but also the bacteria growth. So whenever you have this thick mucus that provides this bacteria growth, and respiratory infections come from that, these secretions then clog the airway, and they promote these infections. It's a wet, dark environment, and bacteria just flourishes in that. They usually have persistent cough and wheezing, and that's from the irritation to the trachea and bronchi. And they'll have an exercise intolerance also. What I mean by exercise intolerance is they have almost like a reactive airway, where their airway gets very irritated whenever they have to, I'm trying to figure out a way to explain this to you, whenever they have to really exert any energy. And so what does it do on the pancreas? So it causes decreased absorption of nutrients, and you also lack adequate digestive enzymes. They can be absent, or it can just be an extreme lack of production. Okay, and all these things cause a multitude of things for the pancreas. Puts them at risk for pancreatitis. Their stools are usually bulky, greasy, foul-smelling, which is the fat that's just going straight through them. They have very poor weight gain, very low body weight. That's because of the lack of absorption of the nutrients. They do have chronic constipation, which can lead to that rectal prolapse and intestinal blocking. And the effects on the sweat glands is it causes that excessive amount of sodium and chloride is excreted. So we talked about a couple of common complications like frequent pulmonary infections, but what else are they at risk for? Straight to death, Jessica, straight to death. Yeah, they're at risk for death eventually. Yes. What happens to their lungs when their lungs are not taking in as much functional capacity, and you have your alveoli that are damaged, and yes, they become hypoxic. They have chronic hypoxia. What happens to that lung tissue when it continues to be damaged and damaged? Does it have the pliability? Can it expand easily? Or is it now tight and stiffer? When you have stiff lungs, what does that put you at risk for? What about a pneumo? Stiff lungs. You have a part of the lung that doesn't want to expand and contract like it needs to. So you have part of that lung that's working properly, and you have a part that's really badly damaged because of the repeated damage to the alveoli. So you have it stiff, and then you have this other really pliable lung that's still wanting to open and close like it's supposed to. Rip, right? It'll rip, and that's what a pneumothorax is. Okay, so they're at a high risk for pneumothorax. Why are they at risk for diabetes? That's right. A dysfunction of that pancreatic tissue puts them at risk for diabetes. And then we talked earlier about how they're at risk for complications of heart failure due to the cor pulmonale, which is the respiratory failure that leads to heart failure. So what do these patients look like? What are their clinical manifestations? How do they present? It honestly is a very wide range and severity of complications. It's usually diagnosed in childhood. We talked about tachypnea, pale, fatigued, thin, barrel-chested, wheezing, coughing, yes. They also have that abnormal breathing. Failure to drive, gross, y'all getting them all now. Yes, failure to drive, gross restricted. They have the pulmonary inflammation, which ends up being that chronic bronchitis. And they have chronic hypoxia. And the signs and symptoms of chronic hypoxia are that barrel chest and that clubbing of the fingers. And how do all these things affect gas exchange? Gas exchange is affected by that thick mucus, but how? You have this thick mucus that's hard to move. They can't clear it easily, so you still have that obstruction. So you have this thick mucus that is really hard to move. And what does mucus usually do in the lungs? What's its job in the lungs on a healthy lung? It traps germs and then it clears them out by either you coughing or getting rid of that mucus. Yeah, it cleans it out, getting rid of those mucal secretions. So now in a CF patient, you have this sticky, thick mucus that's got germs and bacteria trapped in it, and it stays in the lungs, and the lungs become affected, right? And then it just builds up and builds up. It's building up on the bronchioles, on the alveoli. Now you have decreased surface area. All those alveoli are going to be able to expand because they're all clogged around. You know that Mucinex commercial with the little green guy that's living in the lungs? That's what's in there. The little green guys are all over the place. And when it's laying across or inside a bronchiole or an alveoli, it cannot expand. It cannot do its job. You're taking away part of the gas exchange on that patient. So when all this bacteria and germs build up, your body then starts to try to fight it. Your body's like, oh, I got to destroy this. I got to get rid of this. So your immune cells come out. When your immune cells come out, this causes a problem. Why does it cause a problem in CF patients? Why are these chronic infections so bad for CF patients? Yes, chronic infections will cause a constant inflammation. These enzymes, these immune enzymes that come out that actually try to kill this bacteria and germ, they'll actually kill the lung cells. And so these chronic infections end up seriously damaging the lungs because they're not only killing the actual bad cells, but they're also damaging these lung cells, the alveoli and the parts of the lung. So what are some interventions related to gas exchange for the CF patient? We talked about liquefying secretions, and how are you going to do that? How are you going to increase fluids? What else can you do? What kind of oxygen would you give? Humidified, that's right. So that using some type of mist inhalation, so that humidified oxygen. What about nebulized medications? Zopanax, albuterol, Pulmicort. Pulmicort's also a steroid, but it helps them get secretions out. Okay, so you also want to be able to mobilize the secretions, because you've got to get the secretions, these nasty bacteria and germ-filled secretions have now got to get out of the lungs. How do you do that? Yeah, CPT. Postural drainage. You can use those bronchodilators so that they can open up the bronchioles so that it's able to get these thick plugs out. Nebulizer treatments also help with removing. And then you have to prevent these respiratory tract infections. So you have to promptly treat any respiratory tract infections that are coming up. If you suspect a respiratory tract infection, what are you going to have to get? What kind of culture? Sputum culture, that's right. And the sputum cultures, they need to come from deep within the lungs, right? And they can't be contaminated by a bunch of saliva because it dilutes them out. When's the best time to obtain a sputum culture? Morning, that's right. And so how are you going to instruct this patient? What do you need to do or not do before getting this culture? Things that would decrease contamination. Yeah, so no mouthwash and no brushing your teeth. They can brush their teeth with water. No drinking or eating anything, so it needs to be done first thing. So once you get the sputum culture back and it's positive, so you've got this culture sensitivity on the sputum, now is your time for antibiotic therapy. There's oral and there's inhaled antibiotics. Tobramycin is one of the antibiotics that they can be inhaled. They'll also have antibiotics that are oral and IV depending on the severity of the infection. And somebody asked if they're on steroids. Some of them are on steroids. It depends on the severity and the compounds. How are we going to prevent a pneumothorax? What changes in the lungs cause a pneumothorax? What about pressure changes? Would pressure changes in the lungs cause a pneumothorax? So those pressure changes like scuba diving, those are pressure changes that happen in the lungs. High altitudes or extreme low altitudes, those altitude changes. Also, no lifting, like how powerlifting or heavy lifting things. What do you do when you go to lift something up that's really heavy? You hold your breath and you strain to lift it up. What does that do inside your thoracic cavity? Contact sports, I would say no. Yeah, it stresses it and increases the pressure in your thoracic cavity, which can cause a pneumothorax for them. Okay, and then exercises. No intensive exercises or those isometric movements where you're just contracting that one muscle group over and over. Anything like that that can cause them to strain and possibly change their pressure in their thoracic cavity needs to be avoided. Some of your nursing diagnosis, obviously we've covered risk for infection. They have best impaired gas exchange. Ineffective breathing pattern, so they may have the pattern, but it may not be the effective gas exchange that you need. Also, imbalance in nutrition. And then think about their family, so coping with family. So what are some interventions? Hold on. What are some interventions But you want to know. You want to know how you need to help them maintain their nutrition, and how are you going to do that? What kind of diet do they need? What about fat? Okay, so you want to have this high protein, high calorie diet. And then their fat is as tolerated, fairly restricted, but it's as tolerated. So if they can have, let's say they're on X amount of fat and they're able to handle it, and you know that they can handle it because there's no fat coming out, they don't have these fatty stools, then you know they're okay on that type of, that level of fat diet. If they start having fatty stools, then you know it has to be decreased. Okay? And they do need to have a high sodium diet. What about pancreatic enzymes? When do you give them? Yeah. You give them with meals, the first bite of each meal, or snacks. And they're known to cause some GI upset and irritation to the mucous membranes. Any of the ones that come in the coated tablets should not be chewed or crushed. You also need to know that you need to increase pancreatic enzyme with the increase of fat intake. Your fat-soluble vitamins need to be given in water-soluble form. What are your fat-soluble vitamins? Yeah, ADK, that's right. And then postural drainage. So postural drainage will help them. They won't be labored whenever they're eating, which allows them to eat better. So you want to do that postural drainage 1 or 2 hours before food, or even you can even do it up to 3 hours after a meal. You wouldn't want to do it right after a meal. Beating on someone's chest or back after they've eaten will probably cause nausea, right, and vomiting, and you don't want them throwing up what they just ate. You need as many calories and as much food as them as you can get because of their weight issues and their growth problems. Okay, what are you going to do for pulmonary? Yes, Jessica.
So because it has cystic fibrosis, Miss Everly, my first semester instructor, told me that have you ever tried eating like when you're super sick and you can't breathe and it's super hard to chew and breathe at the same time? So would you say that we could encourage them to have like small, frequent meals as opposed to like ginormous meals, or like foods that are easy to chew?
Well, foods that are easy to chew, and that's where postural drainage comes in, to really get them cleaned out well before they start eating, so they don't have that labored breathing, and they're clear of as much thick mucus as possible so that they can't eat well. They do not recommend small, frequent meals. They recommend 3 meals and a few snacks.
Okay.
And that's because they won't ever take in the adequate amount of calories having these small, frequent meals. They end up just picking, and it's hard to get their complete calorie intake in.
Okay, perfect. Thank you.
You're welcome. Okay, so for pulmonary therapy, what are you going to do for that? Postural drainage is one of them. Breathing exercises. What about guaifenesin? What does it do? What does guaifenesin do? Guaifenesin, the little green guy in commercials of Mucinex. It thins secretions. What do you need to do if you're taking that, though? What do you have to increase? You have to increase that fluid intake. If not, it makes it even harder to get it out. But with guaifenesin, it can also cause nausea and GI upset. Okay, so just remember that without increasing your fluid intake for the effectiveness of it, to allow, if you don't increase your fluid intake, it just makes this thick secretions, and now they're coughing, trying to get it up, and they just can't quite ever get it up. Okay, and how do you prevent or minimize these pulmonary complications? Well, same thing we talked about, this chest PT that needs to be done. You really want to push these oral fluids. If they're able to do any little small amount of exercise, you want to promote that. You want to do anything that helps with that lung expansion. and exercising the lungs, whether that's an incentive spirometer. Yeah, I've heard a lot of people say that about clofenicin. You either have this reaction to it or you don't. If you take it on an empty stomach, I've heard it's worse than taking it on a full stomach. I've taken it before and I haven't had any nausea with it, but I do know people that have had nausea. So to prevent these pulmonary complications, we're doing all those things to help with your lung expansion and lung exercises. And then you also need to give oxygen as ordered. Some of them may not need oxygen. It depends on where they're at in their treatment plan. And as always, you're wanting to encourage the family's participation in planning of care. That includes also getting social work and case management involved. Most of these people find out that their baby has CF as a newborn, and it's not the 100% perfect little picture they had of their child, and maybe they also didn't have prenatal lab work done to know if they were cured. And so it's usually a surprise. Now I have some questions for you to see what you learned. So you have a child with cystic fibrosis who's having difficulty clearing secretions. Which nursing intervention is most appropriate? That's right. You want to implement that chest PT up to 4 times a day, and 1 to 2 hours before a meal to really open them up. Okay. Parent with a child with cystic fibrosis asks the nurse which diet is recommended for the child. What is the nurse's best response? Yes, you want that high calorie diet, not necessarily fat restricted, fat as they can tolerate. You want high protein, and you definitely want the diet. They're losing a lot of sodium through their inability to regulate that sodium. Okay, which statement concerning pancreatic enzymes for cystic fibrosis client is correct? That is correct, and because it needs to be replacement for those enzymes, it has to be given a meal so that it can do its job. So what information on nutrition should the nurse include in the family's teaching plan for their child with cystic fibrosis? Yes, high calorie, high protein. No fluid restrictions on them because you need the fluids to mobilize the secretions. No regulate that sodium, so they're losing a lot of sodium. And why would you not give fat soluble vitamins? You need to give fat soluble vitamins, but they need to be in water soluble form, right? We already know they cannot absorb fat. Yeah, that's right. They can't absorb fat well, so they're not going to be able to absorb these fat soluble vitamins well either. Which nurse action would the nurse perform to prevent the most serious complications of cystic fibrosis? What's the most serious complication of cystic fibrosis first before you answer this question? So pulmonary obstruction of some kind, right? Whether that's that leads to a problem with gas exchange. So if you have that mucus that's impeding the airway or obstructing the airway, pulmonary obstruction is your most serious complication. So how are you going to prevent that? Yeah, chest PT, you got to get it cleared out. Someone just asked me, and now it's going off my screen, let me scroll up, about increased sodium intake. You follow their, you don't want to just overload them on sodium, but you definitely do not restrict it. So no sodium restriction of any kind. Yes, Jessica.
Sorry, I have a really quick question, Ms. Waljack. You were saying a certain mucolytic. What mucolytic? What are you saying that you? Is there like a specific one that we use with cystic fibrosis, or is any okay? Because the Lippincott has one, or two, but I don't know.
Which ones do they list in there? Just know anything that's done for expectorant those up.
Okay, yeah, they have the Dornas alpha and then the acetylcysteine,
Yeah, and
cholecystine.
those contain that guaifenesin.
Okay.
Okay, so which is the best method for evaluating a 6-year-old with cystic fibrosis who has been placed on aerosol inhaler? What do you want that aerosol inhaler to do? That's right. Do you think you could tell a 6-year-old how she needed to do it and then turn around and have her do it? No, she's a child. She's 6 years old, so it needs to be appropriate education learning for her, which would be you demonstrate it, okay, and have her demonstrate, have her return that demonstration to you. All right, do you have any questions about cystic fibrosis? Okay, let's go into anemia. Okay, we're going to follow this Miss probably Dyson through a couple of case scenarios. We're going to probably try to kill her by the end of this class today. So she's going to start off here in, she's a 36-year-old patient. She's been admitted to the med-surg unit with acute anemia related to low intake of iron from her frozen diet and has some dysfunctional uterine bleeding. You assess her and you find that her skin is pale, she's slightly dry, her hands and feet are cold. She complains of extreme fatigue and shortness of breath, and she asks you for some warm blankets. Her H&H is 8 and 24. Her vital signs with a respiratory rate of 27, her heart rate is 114, blood pressure is 108 over 65, temperature is 97.8, SpO2 is 93 on room air. Orders for 2 units of packed red blood cell transfusion over 3 hours
I'll wash
each,
my hands.
and then a nasal cannula at 1. So she has anemia. So what is anemia? What part of those red blood cells? Yeah, so you need that hemoglobin and hematocrit, right? So anything less than 10 for hemoglobin level causes a problem. You're anemic by then. And there are a couple of different, or there's 4 different types of anemia, and we'll get to those in just a minute. So it's characterized by this decreased levels of hemoglobin and red blood cells that are either abnormal or low. And how does anemia cause hypoxia? You have this decreased hemoglobin and this decreased red blood cells. So that's right, there's not enough oxygen transport. So it decreases the O2 carrying capacity of the blood, either by a deficient or an abnormal hemoglobin. Good. And how does this affect this gas exchange? It's basically the same thing. The gas exchange is affected because you don't have that O2 gas being traveled and carried around, right? That's how it causes the hypoxia. So what were some of her assessment findings? She had that pale skin, cold. Okay. Her heart rate, her H&H, fatigue. Okay, so what are some general clinical manifestations of this? What happens with the skin? We know that the skin is pale and it becomes cold. What is their hair? Yeah, it's brittle and really dry and thin. What about the fingernails? It's almost the opposite of, yeah, they're spoon shaped. It's almost the opposite of the clubbing. It's the other way. The spoon shaped or concave. And then respiratory, we know they're short of breath. Have dyspnea on exertion. And their respiratory rate increases. And then cardiac-wise, they're tachycardic. What else can they have? They can have palpitations. And they can have postural hypertension. So they have hypertension whenever they stand up. They don't have any regulating capacity of that. One of the big signs and early signs that someone will tell you whenever they have anemia is they have this chronic fatigue. They're extremely tired. They're weak. GI-wise, they can be anorexic. They have nausea and weight loss, constipation and diarrhea. It is bad. I have had it before. It is bad. So they have this constant block feeling. It's a tired beyond a tired that you feel when you need to go to bed. Like you think there's something wrong with you. When I had anemia, I'm pretty sure I had leukemia or something before I actually went to the doctor. That's how tired I was. Yeah, like COVID. I haven't had COVID, knock on wood, but it's supposed to be very bad. Chewing on ice, yes. What about neuro-wise? Well, GI-wise, what about GI-wise? I talked about the constipation or diarrhea. They can have the weight loss, nausea, and anorexia. Their tongue, this beefy red tongue. Their inflamed lips and tongue also. Neuro-wise, they'll have headaches and dizziness. And tingling in their extremities, like the ends of their extremities, their fingers or their toes, almost kind of like they're asleep, but not quite asleep. And then in children and infants, this chronic anemia will lead to growth restrictions in them. So poor Polly here. So Polly's on this Freegan diet. What's a Freegan diet and what effect does it have on her anemia? Do y'all know what a Freegan diet is? Okay, well, we tested on a Freegan diet, but a Freegan diet is someone that kind of obtains all their food that's free. Freegan, yeah, free food. You're right. You're right, Louina. So whatever they can find is what they eat. And some common sources of food supply are basically, most of these people are homeless in some way. The dumpster diving behind restaurants, so they don't have a balanced diet is what this case study is trying to show you. Okay? It's trying to show you that this is no balanced diet whatsoever. So they're at risk for lower consumptions of food that would contain iron, vitamin B12, folic acid, vitamin C, and those are all those elements that are necessary for the production of red blood cells. Okay, so what are the types of anemia? We have iron, pernicious, aplastic, and folic acid deficient. We go into iron deficient anemia first. Who's at risk for iron deficient anemia? Pregnancy, yes. What about someone with a poor diet? Infants, why would infants be at risk? You're correct. Why would they be at risk? Anybody know? That's right. Infants are at risk with their diet is primarily milk. That's correct. So poor diet can also be adolescents. And adolescents, the reason for their poor diet is because of their food preferences at that point, whether it's fast food or eating out, just not wanting to eat fruits and vegetables or eating those proper things that you need to have a complete diet. What about older adults? Are they at risk for iron deficient anemia? Yeah. Why? Because they're old? It can be poor dietary, or it can be from the decreased absorption in the small intestines. Okay. Also, any woman or teenager that has a heavy menstrual flow are at risk. They are bleeding, so they are losing iron when they bleed. In any of those states, we have those slow losses. So, peptic ulcer disease, where you just have those losses in your system. How do you think it's diagnosed? Blood test. What do you want to see in that blood test? H&H, that's right. And how do they present? What are clinical manifestations? What are those signs and symptoms? That can be asymptomatic early on. Yeah, pallor, fatigue. What are the three most common? Yes, that's one of them. Bursitis. What else? Pallor is one of them. That's right, cheilitis. So that cracked corner of the mouth. How do you treat this? Yeah, they're going to take supplemental iron. So when you take supplemental iron, or you increase their iron intake dietarily. And so when you're doing the supplemental iron, it's necessary to at least be on it for 6 months so that you're replenishing not just the level in the blood, but also the body stores. So taking the supplement not just a 1 week thing and the numbers are up in their blood. They also have to replace what has been robbed from their body stores. You also want to evaluate their diet and meet any special needs. So what happens if the person doesn't have, how are you going to increase iron? What are some foods that increase iron? Yeah, so beans, so green leafy vegetables, peas. So if you have a patient who does not like meat and does not like green leafy vegetables, you can't expect them to have a dietary increase of iron. So that's one when you would switch them over to a supplement first without trying dietary increase in iron. That's what I mean by evaluate their diet. What are their preferences? There's no good to have this elaborate plan on how you're going to get their iron up by these foods that they're going to eat that they're not going to eat because they don't like. Okay. So what's pernicious anemia? Yeah, so it's the inability of them to absorb this B12. And it can be from the loss of intrinsic factor like gastric bypass, chronic alcoholism, Crohn's disease. So who's at risk? Those are some of the people that are at risk. It's usually not associated with an inadequate dietary intake. So this person could be eating all the right things to have a proper B12 level, but because their body cannot absorb it or something has damaged their ability to absorb it. Older adults, and that's also because of their decreased absorption in their small intestines. It can also run in the family. Anybody who's been on those long-term proton pump inhibitors, it blocks that intrinsic factor. And how is it diagnosed? How do you think it's diagnosed? CBC. So what's the CBC going to show you? Decreased red blood cells, that's right. Or abnormal. There may be red blood cells there, but they may be abnormal. So either a decrease or an abnormal red blood cells. Yes, they'll have a low B12 in their blood. Their serum folate levels also. And how does this patient present? What do they look like? They have those general signs and symptoms of anemia, but what else can they have? Yes, the fatigue. Ataxia, yes, they can have ataxia. They can be confused. They can also have some mild paralysis of their extremities, extreme weakness, and they can have a vibratory sense, like they may feel like their hands are vibrating. Yes, neuro, they can be confused. They lose that sense of balance, which causes that ataxia. And yes, that red beefy tongue. So that smooth, beefy red tongue, which is glutathione. So how do you treat this? Yeah, it's pretty much in all the anemias. B12 injections. So B12 injections or transnasally. And if they're having a problem absorbing B12 through the intestinal tract, this is probably a lifelong replacement, either intranasally or injections. Blood transfusion wouldn't necessarily help because it may bring it up for the time being, but whenever they go back and they're still trying to have their GI tract absorb the B12 from their diet, they're still not going to be able to do it because just of the inability for it to absorb. And these patients are also at a greater risk for gastric cancers. So some of their treatments are, you're going to give this B12 injections or intranasally. They need to maintain good nutrition, and you monitor them for the gastric cancers. Then we have aplastic anemia. What's aplastic? It's that depression of the bone marrow production of all blood cell types, not just the red blood cells, but all blood cell types. So red blood cells, white blood cells, and platelets. And who's at risk for this? People that have had chemo or radiation. Exactly, people that have chemo or radiation. Some of the anticonvulsant medications will affect this. If they're around toxins, that's right. Dilantin is one of the anticonvulsants that will affect it. So insecticides and arsenic, those are some of the toxins. We said radiation therapy. And then there are about 70% of cases that are idiopathic, which means that no one really knows why they happen, but it's thought to be because of an autoimmune problem. So how do you think these are diagnosed? Yeah, bone marrow aspiration. So bone marrow aspiration will show a decrease in those levels. So they will show with the those general signs of anemia. What are some things they can also present with? Yeah, they can have bleeding problems associated with the thrombocytopenia. So yes, the petechiae, those indications. What about fever? They can present with fever. And then, yes, they have neutropenia, so that puts them at a greater risk of infection. So they may present with just increased infections. Chills. So how are you going to treat them? If it's because of an exposure like insecticide or arsenic or something like that, or even a medication, you want to remove that agent from them. And then sometimes they'll do immunosuppression with them if they feel like it's autoimmune issue and the body's attacking itself. In extreme cases, they'll stem cell transplant. Y'all must have studied before class. Okay, what about the folic acid deficient? How is it similar to B12 deficiency? So both are dietary, right? So the folic acid is a malabsorption syndrome caused by something like drugs, like oral contraceptives or anticonvulsants. Methotrexate will also cause it. Where B12 is a deficiency, it's the failure to absorb. So what are some manifestations of this? Yes, they have the normal signs and symptoms. This can be a really slow onset. It takes a long time for them to start showing symptoms of it. They have extreme weight loss. They become really emaciated. And diagnostic is you have to decide whether this is a folic acid deficiency or B12 deficiency. And then treatment will be your injections, your folic acid injections. Once they do injections and you get it up, then you have the oral replacement therapy. Yes, Jessica?
You said that the pernicious anemia was failure to absorb B12 and folic acid deficiency anemia is just decreased dietary intake. I think you were like naming like the differences, and I just got that the B12 failure to absorb.
Yeah. So B12 is the failure to absorb, like your body physically can't do it, and folic acid deficiency is a malabsorption to where something's blocking it from absorbing.
Okay.
That makes sense?
Yes, thank you.
Okay. So when you're doing the treatments, they need to take the folic acid injections until their levels are up, and then they'll take an oral replacement from then on. And you can also increase dietary intake once you've taken that causative factor away. So whether it's control pills or methotrexate or whatever it is that they're taking that's causing them to not be able to absorb this folic acid, you remove that, then you can increase their dietary intake and it will help also. So with all your anemias, you want to be able, your goal is to identify and correct the anemia. So how are you going to do that? You have to be able to establish a diagnosis. So you have to know what's going on and what kind of anemia you have. So you need a complete nutritional evaluation. You need a history of possible causes. You need to decrease the body's need for oxygen because the oxygen carrying capacity is not there. So they don't need to be exerting themselves when you know you can't oxygenate them properly. So what are some things you're going to do for that? You need to assess the client's tolerance to activity. You may need to give supplemental oxygen. What do you need to do if you're giving supplemental oxygen? Pulse ox monitor level. You need to decide if they're able to do and maintain their activities of daily living on their own. Do they need help with that? Do things need to be modified? And you need to encourage gentle exercise to rebuild their tolerance to exercise. Nursing intervention of preventing infections. How are we going to decrease that? You're going to decrease exposure. Evaluate for temperature. Monitor their neutrophil count. Remember last class we talked about the ANC, the absolute neutrophil count. You want to maintain adequate hydration for those patients also. You're going to assess for the complications of chronic anemia. So what are some of those complications? You need to be able to assess for the cardiovascular system to be able to maintain adequate output. So whenever, heart failure, that's right. So when your body's not getting enough oxygen around, it automatically tells your heart, because it's not perfusing the body properly. It automatically tells your heart that it needs to increase the heart rate so that you can get more there. The problem is, it doesn't matter how fast your heart gets, there's not enough oxygen in the blood to be able to adequately perfuse the body. So your body's automatic feedback is, oh, got to get higher because it's still not being perfused properly. Have to get higher, it's still not being perfused properly. Doesn't matter how high that heart rate beats, there's not enough oxygen in the blood. Okay? So then you need to be assessing for signs and symptoms of hypoxia. What are some of the early signs and symptoms of hypoxia? Restlessness, confusion, tachycardic, right? Tachypnea, disoriented, and that tripod positioning where they want to be in that tripod position to be able to breathe better. Changes in their LOC, that's right. What about some late signs? This goes from extreme restlessness to where they're just kind of in a stupor. They have a lot of trouble breathing. They have a severe dyspnea. Their respiratory rate slows, and their heart rate slows. Those two things cause them to be what? My respiratory rate slows. The amount of oxygen that I was taking in the first place is now even less. And my heart rate slows. I'm now circulating even less oxygen around for two reasons. So they're going to become cyanotic. Not just peripherally, but centrally also. I'll start having these intercostal retractions. Those accessory muscles really start working. And you want to help the patient understand the implications of the disease and measures to maintain health. So they need to understand what their medical regimen is or their medical plan is. Discuss the importance of any follow-up that's needed. You need to be able to discuss with them the signs and symptoms of, the side effects of their medications, both the good and the bad. So some things you would tell them about iron. It can be toxic. What else? That's right. Black tarry stools, not starry tools. Black tarry stools. It can cause constipation. What foods can they get it out of? So those red meats, the liver meats, pork and poultry, and rich cereals and breads, beans, whole grains. And you do want to administer it with fruit juice. It increases, or citric juice, sorry, it increases the absorption of it. So on an empty stomach with citrus juice is best. You need to avoid the use of antacids with it. Let's see what you've learned. So the nurse is gathering data on a client with pernicious anemia. Which data would support this diagnosis? Select all that apply. Pernicious is our B12. I'll do good. Yeah, it's 1, 2, 4, and 5. Very good. Or all but, as Rebecca would. client is admitted to the hospital with pallor, fatigue, dry lips, and a smooth, bright red tongue. The preliminary diagnosis is pernicious anemia has been made. Which diagnostic test would confirm this diagnosis? We didn't talk about this. This is why I put this question in here. Okay, it's the Schilling's test. So the Schilling's test is when the small amount of radioactive form of B12 is given. And there's different stages of it. I don't need y'all to know all the different stages. Just know that they'll follow it through the system to see if it's being absorbed or not. They do it in the different stages because if you fail stage 1, they'll go on to stage 2. So like stage 1, they give it PO and they're trying to see if it comes out in your urine. And then as it progresses, it ends up they're giving it to see if your pancreas is working. So you don't have to know all the levels, but just know it's a small dose of radioactive form of B12 that's given. And the 4 stages are done so that they can see where the breakdown's at. And if they find the breakdown at stage 1, then they stop and they don't do all 4 stages of the test. Okay. Okay, which factor increases the client's risk of developing anemia? That's right. Someone who's had a gastrectomy, they have taken that absorption ability and decreased it by a lot. So it has caused the body the inability to absorb this B12. The client asked the nurse about the common cause of aplastic anemia, and which reply would be best. Yeah, bone marrow suppression. The nurse is reviewing the chart for 4 clients. The client is at greatest risk for the development of anemia. Final answers. This one's a little hard. I know you're going with 3, and it can cause anemia, but there's one that would cause greater risk of anemia out of this group, and that's the patient with chronic renal failure. So chronic renal failure decreases the production of EPO, which is what's needed in the production of red blood cells. So yes, 3 is correct if number 2 wasn't there. Okay, the nurse is teaching a client with iron deficiency anemia about iron therapy. Which statement is made by the client which would indicate the correct understanding of this teaching? Yeah, that's correct. Good, that's number 4. So they'll take it on an empty stomach with orange juice, that it helps with the absorption of iron. All right, any questions about anemia? Yes, you may take a break. How long do you want? I'd say 10 minutes. Come back about 12:25. Okay, I'll be here. Okay, y'all ready? Or y'all back, I should say. All right. So pulmonarism case study. We're still going here with Pearlie. So she's been enjoying her time on the unit, and she's especially excited that you are providing her with such cool stuff as slippery socks and tiny bottles of shampoo. As a matter of fact, she's been enjoying it so much that she's refusing to follow many of your nursing interventions that she's been trying to implement to return her to optimal health. When taking a report from the offgoing shift, you find out that within the last 36 hours that you were Pearlie's nurse, that no one has been able to convince her to get out of bed and move further than the bathroom. When you go in to assess her, she's lying in the bed, eating graham crackers and watching TV. You make her get up and walk down the hallway twice, and about an hour later, Pearlie's call light comes on and she tells you that she's feeling awful. On assessment, you find that she is sitting up in bed, hunched over slightly forward with a look of panic on her face. You check her vital signs and her heart rate is 142, her respiratory rate is 40, her blood pressure is 102/54, temperature is 98.8, SpO2 is 89 on room air. She has crackles in the lower lobe and is diaphoretic. So, what is a pulmonary embolism? So, it's a blockage in one of the pulmonary arteries of your lungs, right? So, it's the obstruction of that artery. It can be from a clot, from air, from fat, from bone marrow, or sepsis. And the severity of it depends on the size of it. Obviously, the larger, the more it is going to be blocking this artery and could, depending on the size, completely block off all circulation in that artery. And what happens then? If you stop all blood flow, death, there you go, death, immediate death. If you stop all blood flow in that pulmonary artery, there is no life left. Okay? So it originates in that venous circulation on the right side of the heart. So who's at risk for these? What's the risk factors? And what caused Pearlie's P? Immobility and inactivity. So immobility is a predisposing factor. It can be a surgery that's happened in the last 3 months. It can be from a stroke, spinal cord injury would be part of your immobility. A history of DVTs, advancing age, and even obesity, part of the immobility because you're just not able to get up and move or have the circulation. You can have a vascular injury that can cause it, so that's damage to those veins, whether it's from surgery or from an injury. It can make you more prone to blood clot. A leg fracture would be something that would be part of that vascular injury. DVTs will make you more at risk for it. And these dislodge due to the jarring or the increase in blood pressure or Valsalva mover. So childbirth, what happens when they're pushing? They're bearing down, and when they bear down, they're increasing that pressure, right? And it causes these DVTs to come loose, and they go to their pulmonary arteries and block it off. Those clots happen when that blood flow is restricted or slows down for long periods of time. Think about, they tell you to get up and walk around when you're on an airplane, or don't sit with your legs crossed for a long amount of time. And then people that just have hypercoagulability of their blood, so they're just more prone to clotting at a greater risk. So what risk did our patient have? She had that venous stasis just from lying around in the bed. What else did she have? Think about in our last case study with her. She had anemia and she was given 2 packs of transfusions, right? So why would that cause her to be at risk to have a PE? Yeah, platelet count, right? So you gave her 2 units of a transfusion, added blood, higher clotting chance. That's right. Exactly right. That's the critical thinking you need to be doing. So she's not only at risk just from being inactive and laying around and have that venous stasis, she's also at risk because you added more blood to her, added more platelets, added more hematocrit, added all those things that put her at risk for having a blood clot. So what are some of the signs and symptoms? Yeah, so they have that dyspnea, they have chest pain, hypoxic, their shortness of breath. They have that feeling of impending doom, and that increases their anxiety. But what actually is that feeling of impending doom? They just can't identify that. What is it? It's air hunger. Yeah, so they have this restlessness and that feeling of impending doom that's drawn by air hunger. They have tachycardia and there's tachypneic. And they have coughing and wheezing. And what are those from? Obviously it's from the PE, but what part of the PE? Blockage of what? No, they have coughing and wheezing due to the bronchi constriction. Yeah, the airway. They'll have hypotension. So why is her heart rate elevated? We know that's a form of compensation, right? But what's her body trying to do? Her heart rate's elevated because it's getting the biofeedback that the blood's not going through. It's not coming back. I need more blood. So now it's like, oh, okay, well, I've got to push more blood to try to get more return. But you're not going to get that return. You have this resistance in your pulmonary circulation in that circuit. So you have this resistance, and it's going to cause the hypotension due to that blockage in the artery or partial blockage in the artery. And that's going to cause that right-sided heart failure. So this cardiac output decreases. The backup of the blood goes into the right side of the heart and causes the decrease in the left side, which causes right-sided heart failure. And how do you diagnose this PE? What's the gold standard? Yeah, the CT angiograph is the gold standard. The contrast is injected right into the pulmonary arteries, and it allows you to visualize the whole pulmonary structure. So it is the definitive diagnosis for a pulmonary embolism. What do you need to tell those patients? How do you prepare them before a CT angiograph? If they're getting contrast, what do you need to make sure they do? Well, you need to make sure they don't have any allergies to shellfish or dye. These patients need to be in a stable condition. They need to be able to be cooperative. They shouldn't have bleeding disorders, and it's a contraindication in pregnancy. You also want to make sure these patients are well hydrated before the procedure because you are giving them that dye. And then after the procedure, that fluid intake to be able to push that dye out of their system and help them get it out. Yeah, and if they have kidney issues, so they can't filter it out. What would their ABG look like? Yeah, respiratory alkalosis. So you have that decreased CO2 and a decreased O2 or PaO2 in the system in your ABG. So what are some of your nursing interventions? You're going to identify the clients who are at risk and prevent or decrease venous stasis. And how are you going to do that? Some of these are back to very basic first semester. Their history, yeah, knowing who's at risk for it. What about encouraging mobility? Elastic support stockings, SCDs. Teach the client about elevating their legs every 20 minutes, every 4 hours. Avoid crossing legs when sitting and prolonged sitting times. Don't wear restrictive clothing. Do breathing exercises. You want to make sure you maintain adequate fluid intake. What about anticoagulation therapy? It's going to help prevent further thrombus formations. And with those, you also need to make sure you're monitoring for excessive bleeding. Another nursing intervention is you need to be able to identify the problems and implement the nursing measures to alleviate hypoxia. How are you going to do that? Elevate the head of bed. Give oxygen when needed. You want to educate them about any activities or actions that can cause them to have the Valsalva mover. Pulse ox to know what their O2 stat is. You need to have access through IV so that you can give fluids and medications to maintain that blood pressure. I mean, why would you give morphine, small doses of morphine? Yeah, morphine is going to decrease that anxiety. It's also going to alleviate any chest pain. That's right, pain increases the need for O2, so you want to keep that need down. And also, if you have to intubate this patient or they become mechanically ventilated, it improves tolerance to the intubation and ventilation. You also want to be able to monitor the patient's respiratory function in response to treatment. Respiratory function you're going to monitor by doing your ABGs, by your assessment for this patient respiratory-wise. And your response to treatment is going to be your feedback. Any change that you do, you need to go back and assess to see whether or not it worked. So what did you learn? A client admitted with for lower extremity DVT is experiencing dyspnea, chest pain, and diminished breath sounds. The nurse suspects that the client may be developing what? Good. We'll continue with lecture today. So which physiological effects of pulmonary embolism would initially affect oxygenation? Good. That's right. So the blood clot blocks the perfusion and produces hypoxia despite being normal ventilation. Nurse is teaching the client about the pulmonary embolism. The client tells the nurse that he has a ventilation perfusion mismatch. Which statement by the client best conveys an understanding of this diagnosis? Yeah, number one's right. So the area of the lung is being ventilated, it isn't being perfused. So that ventilation perfusion mismatch, you have that pulmonary embolism that blocks the flow of blood, but it still has the oxygen function is there, but it isn't being perfused properly. So it blocks the flow of blood, even though the capacity there is there for the lung to actually work. So a client is diagnosed with a PE and tells the nurse that he feels a sense of extreme apprehension. The nurse recognizes this manifestation is caused by, yeah, a sudden reduction in oxygen. That's that air hunger that they have. So a client with a massive PE is scheduled to have an ABG performed. The nurse expects the analysis to identify which condition. Yeah, respiratory alkalosis. So the client is scheduled to have a ventilation perfusion scan. He asks the nurse to explain the test. The nurse tells the client that the test will help diagnose the pulmonary embolism and provide information about. Okay, so the answer is 2. So the scan will provide information on the extent of the occlusion caused by the PE and the amount of lung tissue involved in the area not perfused. It does not address the amount of surface or oxygenation present or the size of the pulmonary embolism. So a client is suspected of having a PE and asks the nurse how a definitive diagnosis is determined. Which test would be done? Okay, angiogram. So you have a definitive diagnosis of this PE made for this patient. So what medication should you anticipate for this patient? Yeah, heparin's going to be started. The nurse is teaching a client diagnosed with a PE about the prescribed heparin therapy. The nurse determines that the teaching has been effective when the client states the heparin is given to, what does it do? Okay, so the answer is 3, slow the development of other clots. So remember, heparin doesn't break up or dissolve existing clots. What heparin does is it stops other clots from forming. It's not going to stop it from traveling to the lungs. It's not going to break it up or dissolve it. That's right. TPA is what dissolves it. So heparin stops that the coagulation of platelets, so it stops other clots from forming. TPA can be a treatment, and it is used. That's a whole other part that we're not going to really get into on this. The problem with TPA is it's not specific to just the clot that, the pulmonary embolism. It's specific to any clot in your body. So there's a high risk of bleed, and there's a certain patient population that cannot have that. A large, very large patient population that cannot have that. That I would have to look up. You're talking about before starting TPA? That I would have to look up. I mean, I would say it wouldn't need to be in your blood. You'd have to have a really low level of it to be off the anticoagulants for it to work properly. I'll look up. If you remind me at the end of this, I'll look it up. Okay, so a hospitalized patient with a PE develops hypotension. The nurse determines it's a hypotension as a result of what? Yeah, 4 is right. So you have that increased pulmonary vascular resistance and the reduced blood delivery to the left side of the heart. So it's backing up in that right side of the heart, and that side's getting flooded. Okay, so a client with pulmonary embolism is experiencing chest pain and apprehension. What's the nurse's priority intervention in this situation? You're right. So number one, you're going to give them something for that. You're past the guided imagery. You have someone who's in there experiencing chest pain and they're getting anxious, and you start telling them to think about the best vacation they've had and what beach they want to be on, and it's going to go south very quickly. So you have to give them something so that they can calm down, and that anxiety and apprehension does not increase their oxygen need, which is going to increase their chest pain if they now have an increased oxygen need. And emotional support. I want to be in the room when y'all try to give that for this patient. So what's the patient's priority intervention for a client diagnosed with a pulmonary embolism? That's right. You have to know the oxygenation status before you can really do any type of delivery of oxygen or even know what's going on. Okay, any questions about PE? Okay, let's go on to ARDS. Okay, so Polly's in some bad condition now. So she's been moved from the med-surg floor to the ICU, and now you've been floated up to the ICU for the day, and you're assigned Polly's care. She's intubated now. She's mechanically ventilated, and your initial assessment reveals a blood pressure of 80/40, a heart rate of 160, a temperature of 101.2. She has orders for a 750 ml bolus of normal saline and to start dopamine at 5 mics per kilogram. 2 hours after initial fluid bolus and dopamine is started, and changes are made to ventilator settings, you have the following assessment. Your blood pressure is 90/53, heart rate is 133, and temperature is 99.7. Her lung sounds are faint, even though she's on a ventilator. They're providing complete respiratory support. Despite an FiO2 of 1.0, her blood glass shows hypoxemia, and the highest pressure alarm keeps going off. So y'all know that FiO2 of 1.0 is 100%. So why does she have dopamine going right now? Is it really being used for her blood pressure? Her blood pressure was 90 over 53. It's not horrible, right? So at this point, it's not really being used for blood pressure. It's being used for renal perfusion. And renal failure is the most common secondary system that fails in ours with acute respiratory distress syndrome. So why is this the high pressure alarm on the ventilator sounding? What does a high pressure alarm tell you on a ventilator? I don't expect you to be a respiratory therapist, but you need to know some of the things that go on with the ventilator. A ventilator goes to give a certain amount of breath, and it can, it shows resistance. It can give, depending on what the ranges are set, a low end range or a high end range, but what it's sensing is that it's able to lung up. When it starts hitting the highest pressure range that you've set it on and not filling the lung up appropriately or giving a full breath what it considers a full breath, it's going to give you a high pressure alarm sound. And the high pressure alarm sound, that's telling you that it's telling you that there's a lot of resistance going on. And what's this resistance? What's that's causing? What's it from, I should say? Breathing over the vent will give an alarm, but it's more of an alarm that they can't get all the breaths in. Like the machine, let's say you have the machine or the vent at 20 breaths a minute, and because the patient is breathing on their own, it can't get all the 20 breaths in, so you'll get a breathing alarm. What happens with acute respiratory distress syndrome is the lung becomes stiff and it becomes hard to ventilate. So you have this pressure set, and it's going to push this air into the lungs, but it's pushing the air into the lungs, and it's about blowing up a balloon. You get all this air in your mouth, and you push it into the balloon, and the balloon doesn't move. It's a stiff balloon, so now you have to go back and give even more pressure to that balloon to even get it to start blowing up a little bit. That's what the ventilator realizes is happening with your lungs. It's becoming very stiff. It's not able to give a full breath because it's meeting all this resistance. So stiff lung is one of the problems that happens with acute respiratory distress syndrome. It's very hard to ventilate. It becomes harder and harder to ventilate this lung because now you're trying to force air into this lung, and that causes that high pressure alarm to go off. So Prawley's blood gas shows hypoxia, right? So with an FiO2 of 100%. So what does this mean? This is a hallmark sign of acute respiratory distress, is that you're in 100% and you're still hypoxic. So you're hypoxic despite the maximum levels of oxygen that you can give. So her lungs are not able to effectively use the oxygen that's being delivered. There's damage to the alveoli, which causes the lungs to stiffen and prevent the exchange to happen, the gas exchange to happen. I know that using a balloon as an example may seem ridiculous to y'all, but if you've ever tried to start blowing up a balloon that's never been blown up before, and it's really hard to get that first air in there to get that balloon started because that latex is still really, really hard and tight. But once you start blowing it and you stretch that latex thin, it's easier to get open. Kind of does the opposite when you have RDS. It goes back down to that really tight, dense stage, which is extremely hard to ventilate because you can't open it up all the way. So what is RDS? This definition changes a lot over time, but it is basically an inflammatory type lung injury. What are some of the characteristics of it? It causes increased pulmonary vascular permeability. So that permeability allows for fluid to get into the lungs. Hypoxia, because you're not able to ventilate properly, because if you have fluid in an alveoli, You can have gas exchange if you have fluid in alveoli. If you have fluid in alveoli instead of air, does your lung weigh more or less? That's right. So you have a lung weight that becomes more. Your lungs become heavy. So you have this pulmonary vascular permeability, and you have a heavy lung. And you also lose some of this aerated lung tissue, which causes greater hypoxia. So what does their chest x-ray show? I put 2 chest x-rays up here. The one on the left is a normal clear x-ray on a healthy patient. You can see a little bit when you follow the spine. You can see a little bit of the white, which is the bronchioles, which is normal. And here over here on the right, this, you're correct, Christine, this is what they call a whiteout. So this is that basically the opaqueness that you see in these. It's a ground glass, considered like a glass that's been broken up into pieces, and it's this whiteness and this whiteout. So everywhere you see white in that lung field, if you look at it compared to the left side, everywhere that you see this kind of black and fairly clear, that's all filled with air. Air doesn't show on an x-ray. Well, it does show. It shows as nothing, right? So same thing, if you were looking for air in a stomach or air in the bowel, it's going to show black like that. You look over here in the lung on the right side, and there's not a lot of air in that lung. So there's not a lot of gas exchange going on in that lung. All this white is damaged alveoli. It's either damaged as far as being stiff and not opening at all, or it's filled with fluid. And the fluid shows up as white also. So compressed alveoli, which is a tissue laying on top of tissue, laying on top of tissue, and their little clump will show up as a white opaqueness like this, and also a fluid-filled alveoli section will show up as opaqueness. So like I said, there's not a lot of oxygenation going on here. You can see just a couple of spots that do have some blackness in them. I wish I had a pointer that you could see, but that do have some blackness in them. And think about that's really the only thing that's doing any productive airway exchange. That's not enough to ventilate and to oxygenate your body properly. So in other words, this acute respiratory failure meets all the following criteria. It's no improvement in your oxygenation, either your patient's in 100%. You have decreased pulmonary compliance. That's obviously misspelled. You have dyspnea. You have non-cardiac bilateral pulmonary edema. So you can have cardiac pulmonary edema, and what that white shows up as is fluid, but it's a different kind of fluid. It's not fluid from inflammation and because of decreased permeability. On a cardiac, it would be fluid. This would be blood instead of just damaged fluid. This would be blood if it was cardiac failure. Okay, so non-cardiac pulmonary edema. And then you see these dense pulmonary infiltrates on the x-rays, which I showed you on the last one. The mortality rate for acute respiratory distress syndrome is about 60%, which that's very high. It's very difficult to reverse. You can reverse it by increasing the pressure that's inside the lungs by using your PEEP. It's also very hard to do if you think about PEEP as you have to have enough PEEP. I'm trying to figure out how to explain this to you since you can't see my hands right now. You have to have enough PEEP to keep enough pressure in the lungs to push the fluid out of the lungs. There becomes a point when you cannot ventilate someone that high. You can't run that high of a PEEP on a patient without blowing their lungs. So when you get past that point, it's very hard to keep that fluid outside the lung because the permeability is coming in and out so easily. That makes sense. I'm going to send you also a clip. It's a YouTube video. It's of a rat lung expanding, and it'll help you understand PEEP, like why you need PEEP to keep your lungs open all the way. It's only maybe like 3 minutes, but it shows you this filling up. So what are some of the precipitating factors for acute respiratory distress syndrome? What are some of the things that have to happen? We talked about inflammation. So what are some of the things that cause inflammation in your lung? What about sepsis? Infection, that's right. We studied last week. Systemic inflammatory response and sepsis will be present. This triggers whether it's from hypoxia, from surgery, from a burn, from a crushing injury, from pancreatitis, a PE infection. It doesn't matter what the inflammatory response is, this is what happens. So when this inflammatory response is triggered in the lungs, what starts to happen in the lungs? You have increased inflammatory, right? And when this increased inflammation in the lung happens, it causes tissue damage in the lung. That's right, lung tissue is destroyed, exactly. So, and when you start having this lung tissue destroyed, you have decreased permeability in that lung, which means now you have fluid building up in the lung, right? Because you're supposed to have enough pressure in the lung to keep that fluid on the outside of that alveoli. And now you don't have that in that area. So now the extra fluid is coming into the alveoli, okay? And because of this buildup of fluid in the alveoli, it causes it to collapse, and or if it doesn't collapse, it stays filled up with fluid, and that is poor gas exchange. Yeah, surfactant damage in cells, yeah. So it takes the surfactant away. You need surfactant to open up those alveoli without ripping them. If you don't have surfactant, surfactant is like the best analogy I know, or the best thing I know to tell you about dish soap. You know how it's really slippery in your hand? Your lungs are covered in that. And so when the lung tissue touches each other, it's a lubricant. That's right. When it touches each other and it opens up and it has plenty of surfactant, it doesn't stick together, so it opens very easily and it still maintains that little alveoli. If it doesn't have enough surfactant and that lung tissue touches each other and it opens up, it's going to stick together as it opens. And when you think about something sticking together as it opens, it damages it, it tears it, and it causes it to not be effective anymore. So as this inflammation happens and you have this fluid coming into your lungs, you're also taking away a lot of that surfactant for the cells. So you also, there's all stages of what happens in the body on acute respiratory distress syndrome. So you have phase 1, and this is where you have that increased work of breathing, and you start having this buildup in the alveoli. And the buildup, what I mean is the fluid in the alveoli. Phase 2, it's when your X-ray starts to show that, you have that white look in the X-ray. Your patient definitely needs help breathing, and that's not with CPAP, that's with mechanical ventilation at this point. Stage 3, this lung begins to stiffen, becomes really hard to ventilate. Your alveoli become enlarged and irregular shape, and they're basically not really even usable anymore. The way that you handle this is you try to manage the time for these lungs to heal. This is when high frequency ventilation comes in. High frequency ventilation is really the only type of ventilation that will allow your lungs to heal. Have any of y'all dealt with high frequency ventilation or had a patient that's on high frequency ventilation before? Oh goodness, Rebecca, so she was sick. And NICU, yeah, NICU. So high frequency ventilation, depending on whether it's a jet or an oscillator, it gives around, depending on which one it is, it gives anywhere from 200 to 400 breaths per minute. And what happens is it vibrates the lungs, so it gives these breaths like really fast, like da 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 da, and it shakes the lungs, and that's how it gets the ventilation to happen. It's not like a regular vent where it is expanding the lung like a regular breath and allowing it to deflate, and expanding the lung and deflate. It's this constant, very fast shaking, and that's what allows the lungs to heal, because you're not expanding the lung, so you don't have the ripping and the shredding from whenever now you're surfactant deficient and you're trying to open, and all it's doing with every breath is continuing to damage the lung. Does that make sense? You have to tell me when I need to explain something differently. Okay, so this stage 3 is really that that stage where you can't ventilate them, and you need to really increase on ventilation. When you're trying to give this lung time to heal, the only way to do that is to not be getting these full breaths and to be using some type of high frequency ventilation on this patient. And then phase 4, it goes into MODS. It's part of that multi-organ dysfunction syndrome where you start having failure. And when this patient goes into this this phase 4 of this, you're really very unlikely to ever get them off a ventilator again, and they usually die in this phase. So what diagnostic tests are used to identify acute respiratory distress? Well, we saw the X-ray, right? So X-ray would be one of them. It's a very, that's a very firm diagnosis when you see the lung white like that. Anything that's white, you know, in gas exchange. And then also your ABG would show that. Yeah, ABG and blood gas, that's right. You really follow that ABG very closely in your ARS patients because you change your ventilator according to what's going on with that blood gas. And that decreasing of the PaO2 and increasing difficulty of breathe or not being able to ventilate them only shows that patient's just deteriorating more. So what are your medical treatment goals for ARDS? One of them is you want to identify the underlying cause of it. So you have that systemic inflammatory response or sepsis, and the sooner you identify that, the sooner you can start turning this patient around. Your gas exchange, you need to help do that through positioning if you're at that point, or you need to be able to support oxygenation through mechanical ventilation. And I talked about PEEP ventilation, which is a regular vent, whether you're using the spontaneous breath, allowing it to give to the spontaneous breath, or whether the machine's breathing completely on their own for that patient, or high frequency ventilation. And you need to prevent further organ failure through blood pressure support. So dopamine, you're going to give dopamine, and what's that going to help? These are all blood pressure medications, but think outside the box a little bit. You're going to give dopamine, renal, very good. Yeah, that's going to help renal. So dopamine is going to improve that blood flow to the kidney. It's going to help with kidney perfusion, renal perfusion. Dobutamine, what's it going to do? Dobutamine pretty much only does one thing. There's no wrong answer. I mean, there is, but there's really not. You need to learn. So dobutamine is that drug that does perfusion. Yeah, perfusion, exactly. But a little more deeper into perfusion, dobutamine is the one about cardiac output. So that's going to help increase your cardiac output. Your cardiac output is going to increase your perfusion all over. And milneuron, what's milneuron going to help? So you're trying to get more blood flow to the lungs. So milneuron is going to increase that vasodilation of the pulmonary bed and allow more circulation and perfusion to get to those lungs. Because your pressure, if you think about it, and this is kind of getting deep, but to try to help you understand this a little bit, when your pressure in the lungs gets really high to where you have, you can't keep the fluid out, you also aren't allowing I'm trying to say this the right way, the circulation to enter your lungs. So everything going into those little bitty blood vessels and capillaries going into your lungs are not being perfused all the way down to the end. So what milneuron is helping you do is increase that dilation in that pulmonary bed area so that you can get as much blood flow and oxygenation as you can in there to have that gas exchange happen. So your nursing interventions on this patient, always you got to maintain that patent airway and improve ventilation. That's that frequent assessment and making sure you're staying on top and you're really watching them and you're evaluating for their difficulty of respiration, like how hard it is for them to breathe, suctioning them when necessary. Ventilator protocol for preventing that secondary lung infection, that VAP, right? So up to 40% of patients with RDS get ventilator-acquired pneumonia. You think ventilator-acquired pneumonia on top of RDS is a good outcome. It's not good at all, not helpful at all. Now you have a compounded, serious problem going on in the lungs. What's another way you can tell if you're properly ventilating a patient? What do you follow? What really tells you whether or not a patient's being ventilated properly? You can go in the room and you can look at a patient. You can go in a room and look at a patient and tell whether they're actually receiving a breath. But does that really tell you if you're properly ventilating that patient? Level of consciousness, yes, but if you think about this patient is sick as snot. This is the sickest of the sickest. Close on O2 numbers. What really tells you if you're ventilating? Y'all know this. ABG, that's right. Ventilation is all about your ABG. I can look at you and you may look like you're ventilating okay, but what really tells me that is the chemistry in your blood. So your pH tells me that, your PaO2, your PaCO2 tells me that. All of those things tell me what needs to be adjusted on that vent. How do I get those numbers right? What helps you get those numbers right when a patient is on a ventilator? If you've ever seen someone on high frequency and they're breathing, 600 breaths a minute on a really sick patient, and it's that constant, they're shaking. They need something for that. A lot of times they need to be completely out of it, honestly. They definitely need some type of sedative or paralytic. Sometimes you have to give them a paralytic. When you give a paralytic, you also have to give a sedative because you can't just paralyze someone because they can't show you that they're hurting or show you their needs if they're paralyzed. You also have to give a sedative on top of that. That paralytic allows them to not fight the ventilator or to fight that high frequency vent so that the vent can do their job. Probably at this stage, being on the floor in the hospital, you've heard what's called a bucking event, where a patient will breathe against the vent or not allow the actual breath from the ventilator to go in all the way, not by their fault, just by them not feeling good or them moving or straining in some area. Then you're not allowing that ventilator to do its job. So those patients need some sedation, and sometimes they need to have a paralytic so you're able to ventilate the patient properly. You're also following those hemoglobin levels to know when they need to be transfused, and obviously your oxygen saturation. What was that key sign of acute respiratory distress syndrome? That's right, increasing hypoxia with what? That's right, increasing hypoxia even at 100% oxygen. And then positioning these patients to help with the redistribution of flow to the lungs, to those less damaged areas of the lungs. It doesn't necessarily have to happen symmetrically even on each side. The damage or the acute respiratory distress, you may see a pocket of it in the left lower lobe, and you need to position them where you can get the best flow, the best air, not only circulation, but also the best airflow. And it'll also help remove some of that fluid in that area of the lung. So that frequent positioning, especially prone to maximize that gas exchange. And then there's kinetic therapy, turning the patient laterally. The beds where you can tilt them, they're basically kind of like in a cage, and you may have seen this on really sick patients that have serious lung damage, drowning patients, patients that have been in fires. You put them on a rotating bed so that you can move them every about hour. You do all positions to keep them from collapsing in one area of their lung. You're also going to be assessing to maintain that fluid balance in that patient. There's a fine balance there. You have to keep them hydrated without overhydrating them. You're really following those serum electrolyte levels. You have permeability changes, so you have shifting in fluids from intracellular to extracellular and extracellular to intracellular. And so you really have to watch your electrolytes there, because one minute they may be diluted and the next minute they may be very concentrated. These patients are on strict I&O and daily weights. Always remember, if you're on strict I&O and you have some perfusion issues go on, it needs to have a catheter, urinary catheter in, so that you can really follow their urine output. Because each little drop spilled on the sheet or missing the cup that they're, you're having them pee, and really makes a big difference on what you give them or don't give them for fluid that day. You need to assess and maintain that cardiac output. You're going to be looking for any dysrhythmias. Remember, your assessment is a complete picture, so it's not just one vital sign. It's really correlating all those vital signs together and those assessments just to get a clear picture of what's going on. You can't really treat per just one vital sign. We talked about ventilation a little bit, and what I want you to understand about PEEP is that part of the ventilator that holds your lungs open at a certain level, and the breath is given on top of that level. So if you have, I don't really know how to explain it to you. That's why I'm going to send you this rat lung video. It's the best way I know how to explain it to you. PEEP is what can keep, because in between your breaths, your lungs do not completely collapse all the way down to the bronchial tree. They just don't do that. There's a certain amount of pressure that's allowed to stay in your lungs to keep them completely inflated, and then you take an even bigger breath on top of that. And when you have, when you are using a high PEEP, it compromises the venous conturn. Oh, good. Actually, I've never heard someone else explain it about the balloon that way, but I try to just use the basic things to really help y'all understand how things work. Because when you start talking about lung tissue expanding, it's like sometimes everybody just stops listening because it's a lung. But if you really think about the dynamics of something like a balloon, whenever you have a lot of PEEP going on in your lungs or high PEEP going on in your lungs, it decreases, it causes compromise in that venous return. It decreases the preload of your heart. Okay, so always remember that. Like, you've got a lot of PEEP going on. Now you're going to have some cardiac problems because you're trying to ventilate this patient, which you have to do because you have to have gas exchange. At the same time, you're using these high levels of PEEP, even a medium level of PEEP, it's going to affect your cardiac output. It's going to decrease that preload of your heart. Okay, so high PEEP, a lot of pressure, it's going to affect the cardiac. It's a decreased preload. Also, when you're ventilating someone at high pressures, what do you run the risk of? On a patient like this should always be in your mind. Popping along, that's right, a pneumothorax, either whether it's a tension pneumothorax, whether you just blow it because of the pressure, it happens. Yes, Jessica?
Sorry, you said it was high PEEP, low cardiac output, or high cardiac output?
Low. It decreases that, the preload, basically. So it's really hard. When you have that high PEEP, it's really hard for that venous return. You compromise the venous return to the heart. And there's a fine line when it comes to someone who it's very hard to ventilate and is this sick. There are times that pneumos do happen because you don't have any other choice. It's if you don't perfuse them any better, you can't live with a blood pH of 6.7. It's not possible. So that's the point where you're at on sometimes with these patients. And you have to just, I mean, it just sounds bad, but you have to risk going up on the PEEP or the pressure of this patient ventilating while you're trying to fix other things to get that, your blood gas up, your levels where you want them in the blood gas. You're also talking about a lung that's damaged and that's stiff, and a lung that's damaged and stiff, it has no elasticity in it. Ventilating is hard in the first place, and that can cause a pneumosis in itself. I know y'all just can't wait to get out and nurse in the ICU now. And then I always try to close with what's important for the family. So this emotional support, not only to the patient, but to the family. A lot of times the patients don't know what's going on in this stage of their care. You just need to really be careful with your explanations of the procedures and make sure you repeat that to the family. Families sometimes hear what they want to hear. So that repetitive, concise information repeated back to them over and over and over helps them in a stressful situation comprehend what you're saying and understand what you're saying. They don't understand medical terms. You have to put it into their wordage, and that reinforcement of that really helps the family. Think about one of the most traumatic things that ever happened in your life, and then someone giving you really important information. You're not listening to that. You're not listening to what that person's saying to you. So it's on repeat. You have to tell them over and over and over again. Always make sure, no matter what's going on in the room, that you're confident, the family and the patient's alert. Always make sure that you're available during the visiting hours in the ICU to explain the procedures and equipment or any changes that have happened. Me being in the NICU, one of the first things I try to do whenever I'm consulting with the family or have a come in for the first time to see their kid, that bed space with all those monitors and all those machines that they have no idea what it is, and all these tubes and all these lines hooked up to this kid, when you start breaking it down and tell them, well, this one's the heart, well, this one's giving me the arterial pressure, this one's ventilating, it makes it not seem as scary. Even though it's just as bad, it's not a completely foreign concept. And then, the NICU kids are in there for a very long time, but then you'll overhear, they'll have a family member will come in to visit with a parent, and the parent will be explaining what those machines are to that patient. And then like you've gotten through to them, that not every alarm's scary. The kid's not dying because this alarm's going off. It's very, the same thing with adult patients. You put someone in a room and you have all these alarms going off and machines going, and it's very overwhelming for that family. So it's big to just maintain open communication and be there for them. I know sometimes you want to avoid families, and I understand, but unfortunately it's part of it. Okay, now that you may be overwhelmed. Oh, it's so much a part of it. And they appreciate it so much, even though you may get the brunt of them being scared and they lash out. You give them information they don't want to hear, or there may be a backslide that day. It's just part of it. Okay, so a nurse will explain the process of ARDS syndrome to a client and their family. How should the nurse best describe this disease? Good. That's right. It's 3. So those alveoli spaces become filled with fluid. And if they're filled with fluid, they're not exchanging gas. It's an ST for life. So when a client is receiving a PEEP therapy, the nurse anticipates the client will exhibit what? Very good. So don't just let that become a word to you, reduced cardiac output. What does that look like? What does that patient look like? How does that show up in that patient? Yeah. That's the one thing I want y'all to understand, and it's part of critical thinking, is don't let words like reduced cardiac output just be that word, reduced cardiac output. Always think about, what does that look like on a patient? Right? That's hypotension, that's, all these different things. Okay, the nurses place the client diagnosed with ARDS in the prone position. The nurse determines that this position would So your cardiac output wouldn't be affected by the prone position. Prone position is going to help accrue more alveoli to open up, and it's going to help with respiratory. Just kidding, huh? It's going to help you with respiratory function and just the recruitment of alveoli. It takes the pressure off of your lungs a little bit. And that's the last one I have for ARDS. Some of them, I'm going to put y'all some more questions in the prep view that you can do just on your own like I did the other ones, and I'll make sure I do them to where y'all can see the answer at the end. it takes pressure. Jessica's question is, how does it recruit? By relieving pressure. You're in a different position. There's less, if you can lay on your stomach, think about this. If you lay on your stomach and you try to breathe and your lungs are heavy and they're filled with fluid, it is harder to breathe than laying, it's easier to breathe than laying on your back. It's a different way, because you're always, when you're sitting up always or you're laying down flat always, it causes the patient to accumulate in that part of the lung or the alveoli. So if you turn them and put them prone, now that fluid is leaving that area. So you're opening up the back part of the lungs. Does that make sense? Okay, good. Yeah, she can get a raise in the bar on this too. What questions do y'all have for today?
Ms. Ralchak, I have a question for you.
Yeah.
If, I mean, God forbid, we did not pass this exam, do we remediate with you or Ms. Donaldson?
You'll know who it'll be. Like, y'all have to understand, I want to go over the test with every single one of y'all, but last semester, because, and I'm glad that everybody got to do it, the ease of being able to do it through Blackboard Collaborative in like 15-minute sessions, I was spending, because I have, 60 students, I was spending 15-minute increments at 8 hours a day going over tests. So she's going to have to help me this time do some of them.
Mm-hmm.
So I won't be able to tell you who will get who. It'll just be whoever's up next, honestly.
Okay.
But yes, you will have an opportunity to go over your missed questions, not the whole exam, the ones that you missed.
Okay, perfect. Thank you.
And I do believe that's very important to do so that you can know where your train of thought went wrong and what your thinking process should have been on a question. Anything else? Okay, do I have any homework assignments for myself this week that I'm supposed to do for y'all? Oh, I need to go into Prep U and the student view and see if you can set up your own question. I'll do that and I'll send out an email. I know, you'll always give me homework assignments. It's all right though. I have homework on this side too if I want to do it right. Is that all this week? I just have one thing I need to do? Oh, yeah. Raising the bar. Okay, 2 things. My lists are getting shorter then. I'll do the raising the bar for immunity and gas exchange. Oh, I'm glad that's helpful. And I will go in and set up extra questions. And like I said, they are not mandatory, but I think they do help you a lot if you use them and questions help you study. Not just if you get the right answer, but also why you got the wrong answer. Oh, yes, I will. Did I not send the immunity one last week? See, my list is growing. Okay. If I didn't send the immunity one last week, I will send it with the gas exchange when I send today. And I apologize for that. Okay, if you need anything between now and next week. Oh, yeah, okay, yep, gotcha. Okay, if you need anything between now and next Tuesday, you know how to get in touch with me. And anyone who's tried to reach me, you know that I'm accessible through text and email or phone call. All you have to do is do it. Okay? All right, y'all have a great week.